Hi, I'm Charity Coe Christensen. I'm a physician assistant and a doctoral candidate at MCPHS University. Today I want to talk about head injuries, but first, a few quick notes. This is part of my capstone project for my doctorate degree, and this talk is for healthcare professionals. It has some evidence-based recommendations, but is not a substitute for clinical judgment. Let's get started. Head injuries is a pretty broad topic. Let's narrow it down to talking about the early use of hypertonic saline for patients who sustain traumatic brain injury or TBI in an austere setting. Of note, hypertonic saline may also benefit other polytrauma patients with hemorrhagic shock. In well-resourced urban centers, it's a quick trip for patients with a TBI to a hospital, oftentimes with CT scanners and access to neurocritical care resources and a neurosurgeon. However, in rural areas, this is not the case, and patients may have hours of transport time or care in a facility without advanced capabilities before they're able to receive the same care as someone sustaining an injury in an urban center. When I think about what types of treatments are needed in an austere environment, I want something that can be given based off of clear protocols, is physically easy to administer, and of course, travels well. Now, let's get into the details. All patients who have a traumatic brain injury should be assessed using a Glasgow Coma score, with each component recorded separately, and this score should be reassessed frequently and, if possible, documented on a flow sheet. Patients with a Glasgow Coma score of 12 or less, or a drop in Glasgow Coma score, should be treated for possible rising intracranial pressure. Let's take a closer look at the evidence behind these recommendations. You can see the references and levels of evidence listed on the slide, but the initial Glasgow Coma score often under-triages patients and their severity of traumatic brain injury. So instead of waiting for a significant decline or other findings of intracranial hypertension, early treatment with hypertonic saline may improve outcomes, especially in patients who have a long transport time to advanced neurocritical care. On to recommendation number 2. Acutely injured patients with low blood pressure, evidence of hemorrhage, or a Glasgow Coma score of 12 or less should receive an initial fluid bolus of 250 milliliters of 3% hypertonic saline by peripheral IV. Now let's look at the details behind this recommendation. Motaharinia et al. Found that a bolus of hypertonic saline given early provided survival benefit for patients with TBI and polytrauma patients with hemorrhagic shock. Dubick et al. Took a closer look at another trial and found that 250 mLs of 3% hypertonic saline improved survival in patients with traumatic brain injury or polytrauma. Now, you might be asking yourself, what about mannitol? Let's look at mannitol versus hypertonic saline. Mannitol acts as a diuretic and can complicate things in patients who already have a low blood pressure. It also has a really narrow temperature storage requirement where hypertonic saline does not. And lastly is time. Mannitol is much harder to administer because it has to use a filter, whereas hypertonic saline can be given quickly by an established peripheral IV. Now, you might be asking yourself, what about kids? Hypertonic saline is effective at lowering intracranial pressure in pediatric patients, and it's safe to use in patients as young as 1 month of age, but you have to dose it according to body weight. Hypertonic saline is safe and effective in treating TBI in austere environments, but you should consider giving it early before other crystalloid fluids in patients who have hypotension or a low Glasgow Coma score. Now, what do you think? Take a few minutes and let us know. There's a survey link in the comments. Thank you so much for your time. Here are my references, and I'll also post them in the comments section for further